Welcome, everyone. Thank you for being here. Welcome. Good afternoon. My name is Relisha Pena. I'm the Assistant Director of Career Services at Columbia School of Social Work. So before we begin, let us take all a moment to reflect on the lands of which we reside. We are coming from many places, and we want to acknowledge the ancestral homelands and traditional territories of Indigenous people who have been here since time immemorial, and to recognize that we must continue to build our solidarity and kinship with Native peoples across the Americas and across the globe. The land acknowledgements do not exist in past tense or historical context. Colonialism is a current ongoing process, and we need to build our mindfulness on our present participation. We also acknowledge, or want to acknowledge, that this country would not exist if it wasn't for the enslaved labor of Black people. We honor the legacy of the African diaspora and Black life, knowledge and skills stolen due to violence and white supremacy. While the movement of justice and liberation is ever present, we are witnessing the power of the people, and many are still being met with violence. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. Please take a moment to consider the many legacies of displacement, migration, and settlement that bring us together here today. Let us also commit to taking what we learned today, incorporating it into our lives, our work, and turning our words into action. Let us take a moment for contemplation. Thank you. I'll also add a few resources in the chat to continue the conversation about these truths and to connect it to our topic today. I also want to welcome our Assistant Director of Career Services at the Marxe School of Public and International Affairs, Samantha Bruno, who will also serve as our moderator for the panel today. And she has a few announcements before we introduce our guests.
Welcome everyone for joining this panel. Welcome to the Marxe School of Public and International Affairs at Brooke College, Columbia School of Social Work, our CUNY partners, and the MSW Career Consortium of New York City. Just an overview of today's event. The first 45 minutes will be a moderated panel. Then we'll open up the breakout rooms for you all to engage in smaller groups. This first half will be recorded, so we ask that you all please mute yourselves, and it is up to you to keep your cameras on or off for the discussion. We'll then come together for the last 5 minutes to do a wrap-up session. So given the breadth of the issues that became prevalent and pervasive in our communities in the last 2 years, our goal today is to learn about the innovations in health equity work, given that the pandemic has brought many inequities to light within the underserved and under-resourced communities. So we are very much looking forward to an engaging conversation with our panelists, which I'll start to introduce, beginning by Sasha Ahuja, the National Director of Strategic Partnerships at Planned Parenthood and Adjunct Professor at Columbia School of Social Work, Natasha Brooks, Senior Associate of Program and Project Delivery at Evidation Health, Tala Monsi, the Associate Director of Health Equity Metrics and Improvement at Planned Parenthood, and Dr. Zahara McMahon, Acting Commissioner for the Bureau of Brooklyn Neighborhood Health at the New York City Department of Health and Mental Hygiene. So thank you all for joining us and being our panelists today. So to get us started, could you tell us about your career journey, including your current position? How did you get involved with the work that you're doing now? And if we could have Sasha, would you please start us off?
Sure. Hi, everyone. Thank you for having me. A privilege to be here, and thank you for your time. I know it's valuable, so thanks for spending some of it with us. My name is Sasha Ahuja. I use she and her. My day job, I serve as National Director of Strategic Partnerships at Planned Parenthood Federation of America, the national Planned Parenthood organization. I have the privilege of working with another one of our panelists, Tala, so really excited for us to collaborate and share some through lines. I'm a native New Yorker, a lifelong organizer. I started in this work when I was 17. I started working in the labor movement here in New York City. My dad drove a yellow taxi in New York, and I grew up in New York City in a post 9/11 city where Muslims, South Asians, and people perceived to be Muslim and South Asian were heavily targeted by law enforcement, by the NYPD, heavily surveilled and monitored, young people included, and was very radicalized by my dad's work, a very public job with very public visibility. and got connected to the union that was organizing taxi workers in New York. You may have seen some of their recent fights to get better dignity as a result of for-hire vehicles on the job. Lots of protest activity that took place in the last year around that we saw around the sort of criminal medallion system in the city. From there, I have been organizing my whole life and went to social work school, particularly because I was oftentimes in policy spaces through organizing, but knew that like none of our people were actually there. Those spaces intentionally leave Black and brown folks out almost by design. And I thought, like, what is the career and the sort of place where we can serve as intermediaries? And that to me was social work, where we can facilitate our people being at the table and also making more seats at every single table to actually influence and shape policy decisions, of which we are experts on, because they are literally, our lives are being litigated in courtrooms and in courthouses and in Congress every single day. So I'm currently at Planned Parenthood, lots of stuff on health equity to talk about there. I had the privilege of working at Planned Parenthood about a decade ago at the New York City office. And so like have that local experience as well. But very grateful for social work as my career choice, that although I've never practiced clinically, I use my social work skills at work every single day. And so excited to dig into that, and particular like how a macro lens to this work influences my life's work, which is ensuring that racial equity and racial justice is part and parcel of how we're driving forward our vision for change. That's it.
Wonderful. Thank you so much. And you actually gave us a good segue to Tala.
Thank you so much. Thank you all for being here, especially I know the Columbia social work students are in finals week, so we really appreciate this time, and we hope that we can use this space to build community. Similar to Sasha, I am a native New Yorker. I was raised by 2 Palestinian refugees, so topics around equity, justice, state-sanctioned violence, occupation were really normalized from a really young age. And absolutely influenced my personal and professional choices to go into a career fighting for human rights. So we all have the same opportunity to really live our potential. And really through my own identity and through my own education and upbringing, I learned really early on about how white supremacy manifests as a global institution. That brought me to a career in international development. I worked for a global youth leadership development organization for 5 years, and then I worked at UNICEF for 5 years, working on the global polio eradication initiative, which specifically is working to end polio, which is endemic in only 2 countries today, Afghanistan and Pakistan. And I joined Planned Parenthood pretty recently, less than a year ago, where at Planned Parenthood, my role is to lead our federation's effort to advance health equity, which looks like identifying a framework and an approach to advancing health equity, creating a roadmap to operationalize health equity, to bridge equity from theory to practice, and identifying the right measures to really look at patient experiences, patient outcomes, and systems transformation. So that is really my work at Planned Parenthood. I think that, similar to Sasha, we can't have racial justice without a focus on healthcare. And I think that's what really brought me to health and public health. I think it's so interconnected to achieving racial justice. And it's intersectional and with so many issues. So I'm very, very humbled and happy and proud to be working at an organization that's very loud about dismantling white supremacy and its connection to improving healthcare. And that's me.
Thank you so much. At this time, I'll bring Niteesa to the floor.
Hi, it's really great to be here today. Really excited to be on this panel. So I'm Natasha Brooks. I think similar to Tala and Sasha that have, talked. I was an athlete at a very young age, and I think for me that's where I saw a lot of injustices as a woman and as a Black woman in general. And so I had always been in tune just around like social sciences and human behavior. And I wanted to always work with people. And so in undergrad pursued my bachelor's degree in psychology and sports science. And then grad school, I graduated from Columbia School of Social Work back in 2018. And a lot of the work that I've done has been around African-American women and their experience with physical activity. A lot of times there's a perception that African women are lazy, and that's not actually the truth. And so the work around that was putting together focus groups to really understand and get a better understanding of women's experiences around physical activity. I've also implemented school-based mental health programs in urban communities in New York City and in Harlem, done a lot of work in sports psychology around sport activism, making sure that specifically women feel comfortable sharing their views around social injustices, around police brutality, around injustices within the sport industry, and how they're perceived in the media as well. Currently, I am a senior associate on the project and program delivery team at Evidation. It's a really cool job and experience that I've had there. And so I work directly with pharmaceutical companies to execute digital research studies. And so if we think about how research studies are typically run, a lot of it is in person. And so what Evidation has done is really navigated the space and has been really innovative to say, you know, how do we track people's everyday behaviors and include that into a research model where we can give research companies and pharmaceutical companies a better understanding, not only how they're responding to medications, but what do their daily lives look like. And so it's a mix of everything. I think Sasha hit it. I'm not necessarily a social worker, but I use a lot of my social work skills because I'm working with a lot of different people. A lot of it is still around policies with like the FDA and ensuring that we're, following good clinical practices as well. And essentially, Evidation is an app. It's a privacy conscious health tracking tool that rewards people that join the app for taking daily health actions and participating in research. The app also allows people to connect, or allows research companies to connect with individuals just around like health engagement programs as well. And there's also a community as well. There's over like 4 million people that are on the program as well. And so the purpose of it is to make sure that people are able to, track their everyday behaviors, whether they're involved in a research study or they're connecting their Fitbit or their Apple Watch to the app and being able to track their daily activities. And more broadly, the Evidation community includes healthcare providers, academic researchers, patient advocates, different things like that. So really excited to be here and yeah, thank you. And that's me.
Of course, thank you. And last but not least, Dr. Zahara McMahon.
Excellent, excellent. So nice to meet everyone. Thank you for your comments and for sharing a bit about your journey. And thank you all for the invitation to join this particular conversation today. So my name is Zahara McMahon. I'm the Assistant Commissioner for the Bureau of Brooklyn Neighborhood Health, which sits in this remarkable Center for Health Equity and Community Wellness, which is then embedded in what we all know as the New York City Department of Health and Mental Hygiene. And I flagged that just to say that something like a Center for Health Equity and Community Wellness within a Department of Health and Mental Hygiene is quite rare and is an important moment for the Department of Health and Mental Hygiene to be putting forward, as many of you all have shared, the right language and then the right action around equity and justice. And so a really exciting moment for many of us who are here within the agency. I guess I would, similar to the folks on the panel, taking a step back and thinking about what did the beginning of my own career trajectory look like. I, like many of the folks who have spoken, had a really early interest in both health and justice. But I would say like in that kind of undergraduate experience, I didn't have the right language, right? But I recognized those were the two spaces I was in, playing activist functions and then learning about health and not understanding how to put that work together and how to act upon it. And it probably wasn't until like my junior year and then moving into my master's experience where I could find the language and find the communities to be a part of that to help me think about and then tackle those questions. The remainder of my career, it really took me into spaces both in the US and across other parts of the Americas, and then within the Middle East, East Africa, and South Asia, and really focusing on public health practice, on research in public health, and then on focusing on communities that have been pushed to the margins for a variety of political, social, economic, and historical reasons. And the combination of that work has sometimes looked like being focused on cardiovascular disease or maternal health, or considering health worker education and partnering with community health workers. And so the topics always change, but the question of whether or not there are inequities, and there almost always are, and whether or not we have addressed them appropriately, and we almost always have not. And then what are the actions that we're going to do that are more radical than what we have been able to do in the past? And those have been the central conversations and then actions that I think have driven my own career forward and have inspired me to stay, I think, in a field that it can be really hard, right? And as we've seen in this current COVID-19 moment, for many of the folks I imagine who are on this call, both personally and professionally, just recognize that public health is a calling, and one that is quite challenging in some of the harshest moments in time, as is social work and anthropology and a lot of other fields that touch health in a variety of different ways. And so it's been a real honor to serve in the profession, and then to be in this particular role here at the Department of Health and Mental Hygiene. And this role currently, in partnership with Yul Napier, who's on as well, is really about us sort of supporting North and Central Brooklyn in the reduction of health inequities across a number of different topics. And so in the remainder of the conversation, I look forward to talking a little bit more about those. But how do you bring together public health practice, the research space, and the data? How do you think about centering folks who have been pushed to the margins, in many cases purposefully, right? How do we do that? And how do we flip what it looks like to be engaging with communities? And so it's a really exciting time to be in the space. And my own career progression, I think, has just been continuing to add the skills and the talents and the language to my tool belt. And so I love this opportunity to be able to talk to folks moving through different parts of your career, because that's what you're doing all along the way, is adding the skills and the talents and the language and the networks that you're a part of, and being able to center social justice and being able to center equity in this work. And so thank you so much, and a real pleasure to meet everyone.
Thank you so much. This is wonderful. Thank you to all of our panelists for those great introductions. I really appreciate hearing, this is not only just a profession for you, this all ties into your personal, your beliefs, your values, and whatnot. So I'll throw it, anyone can take this one first. What is advocacy to you? And what does it look like in your role? I think sometimes when we're thinking about careers, we do tend to think of what are the day-to-day things. But, feel free to incorporate, what does it look like to you in your research, et cetera, and your thought processes, and whatnot.
I'm happy to share a little bit. When I think about health advocacy and advocacy more generally, it's really, I think about mobilizing power towards decisions that need to be made, right? Or towards the redistribution of resources, towards a variety of things. And it is not easy, right? It's definitely a long game. Oftentimes, I think sometimes we step into an environment thinking ambitiously that if we do something today, or many of us do something today, that like this summer, it will be different. And it's just a recognition that health advocacy and advocacy generally is this long game. And it requires a great deal of pressure from many different perspectives. And so it requires a lot of networking, right? And sort of building of power. And so I love hearing from the folks who are on the panel who are talking about being community organizers, because that's the center of how we build power and then how we push on systems that need to change. When I think about the work, particularly within the Bureau of Brooklyn Neighborhood Health, where I am, one of the areas we are focused on in relationship to advocacy is maternal health and birth equity. And specifically in New York City, right, this is a concern for Black women and for Puerto Rican women. And because the data shows us the dramatic level of inequities that exist between these communities and white women and birthing persons within the city. More specifically, Black women are nine times more likely to die as a result of pregnancy-related causes. And that really just shouldn't still be the case, shouldn't still be in existence, should have never been the case, right? And should have never been true. And yet it's something that we're now seeing like lots of movement and momentum. And so people feel like this is the moment. And what we highlight in relationship to advocacy is this is a moment that's been in the making for more than 40 years, right? And the folks who played roles were activists. They were healthcare workers and providers. They were folks within hospital systems. They were doulas and midwives. They were birthing families who had been impacted by horrendous experiences in a variety of different settings. And so the things I would flag, is that advocacy is about power, that advocacy is about a long game, and that it is about the reaching out way beyond the networks that we are in recognition that in order to push back on power, you have to push from every perspective, inside government, outside government, right? In community-based organizations and faith-based organizations. And so that inspires me to see that kind of pushing. And so this moment in maternal health and birth equity in New York City, it's not a moment, right? It is decades and decades of effort in the making from a variety of perspectives that sometimes are forgotten when we're celebrating the moment that we're in. And so that's my sense of advocacy at this point in time, and just really excited to be on a panel hearing from folks who are organizing in many different ways. And I think that's the centerpiece of the work. Thanks so much.
I'm happy to jump in next. When I think of advocacy, at minimum, I think about speaking up and, advocating for the people that you are representing. Similar to what you said, Dr. McNatt, speaking up for Black women, and their rights, that's at minimum what you should be doing for advocacy. And what it looks like in my role, I'm working more on a macro level, working with pharmaceutical companies. So advocacy looks like if we know that we're doing a research study on women that have lupus, we know that that touches Black women, Latino women specifically. And so the data that we're collecting should reflect the people that are mostly affected by that disease. And so when I'm having, and my company in general, when we're having those conversations with pharmaceutical companies, it's letting them know, this is the percentage of people that we're going to recruit for this study, because this is what is going to reflect who is affected by this disease. And if at any case you want to publish that information or use it in other research studies, it should be reflected for the people that, are experiencing that disease. It shouldn't be skewed to white women, because that's not the majority of women that, are affected by that disease, whether it's lupus, whether it's cardiovascular disease, whether it's diabetes. Not only that, but advocating for the people that are in the research studies. So we want to make sure that we're also compensating them for their time as well. If they're involved in a research study that's anywhere from 6 to 12 weeks, we want to make sure that we're compensating them, at the value that they should be for their time as well. Also ensuring that their data, is private. That's another thing that's going on as well, as advocating. At Evidation, all the data is consented. Participants have to consent. in order to participate in the study and to also share their data. That's part of advocacy too. Data should not be shared at all, you know, as if people are not consenting to. And I think once you start to dive into healthcare and health advocacy and health equity, a lot of it is around consenting and making sure that, you know, participants, when they're involved in these research studies, that they're agreeing to have their data shared to the pharmaceutical company that's doing the research, or, you know, the sponsor company as well. Another piece to that too is ensuring that their time is of value and being transparent with them, whether it's a focus group, whether it's answering surveys. This is the amount of time that they have, and a lot of that is part of advocacy. We know that we're all busy in our everyday lives, and ensuring that we're being respectful of people's times, that's part of the advocacy too. So it's standing up and saying, like, you know, I don't think we should do X, Y, and Z, or I think we should do this or go this different way. And it's okay if people disagree with you. Part of advocacy is speaking up and not letting your voice be silent. So that's my take on advocacy.
The only thing I'll add to that, thank you. That's so helpful to just build on just a little bit. I also feel like part of this is just getting out of people's way. Like, we are not in a place where we need to be speaking on behalf of all the time. And social workers, I think this is what we're trained to do sometimes in school, is speaking on behalf of, rather than actually creating the space and then taking a step back, and creating more space and taking a step back, and ensuring that folks that are directly impacted are the ones that are leading the charge in the fight. And that comes out of, as Dr. McNatt said, organizers who are on the forefront, and then also leadership in this work. To the point that you raised, Dr. McNatt, the movement in New York around finally centering grave inequities that Black women in particular in our city face when it comes to birth outcomes, which, you know, those are a set of policy decisions made very much so on purpose, and finally it has gotten light. The work that folks are doing now was decades of organizing and decades of providing direct services by Black women, for Black women in their communities in trusted ways, and also leadership at the New York City Department of Health about 8 years ago from our former 2 commissioners ago, Dr. Mary Bassett, who's now our state health commissioner, who unapologetically centered racial equity in her leadership, serving as commissioner. So both feel possible, like grassroots movement to continue to make sure our communities are centered, and then leadership at the very top who's going to be unapologetic about their mission. And like in the best case scenario, those 2 things meet in the middle, as we're seeing on a renewed focus, or maybe a first time sort of much more absorbed focus on addressing Black maternal health equity in New York City in particular.
Thanks for that, Sasha. I have so many thoughts in response to what you just shared. I think Race to Justice, the internal reform that DOHMH took on to really address racial equity, certainly impacted me in my journey as a health equity professional. So I really commend the Department of Health for that longstanding effort and longstanding commitment. A collaboration that Sasha's team, Strategic Partnerships, and my team, the Health Equity team, have been working on is making direct investments in reproductive justice organizations. So, you know, Planned Parenthood is a direct service provider. We're also a reproductive rights organization, but it's really the reproductive justice movement that was founded by Black women and is led by women of color, that really brought attention to the fact that women's rights is a deeply intersectional issue. It's the Black RJ movement that really made reproductive rights and reproductive health a more intersectional movement issue. And it's really these organizations that are at the forefront of fighting for liberation and justice and rights for communities to have autonomy over their bodies, for their own reproduction, to have healthy lives for their children. So I think that's like one of the ways as Planned Parenthood we're creating space and stepping back and just trying to be very, very mindful of. In my role, I would say most of the advocacy that I'm doing is advocating to senior leaders, particularly leadership teams at Planned Parenthood affiliates across the country, to prioritize and make significant reforms to advance health equity. I think health equity is something that many leaders embrace in theory, but in practice takes a lot of transformational change to really make happen. It looks like really getting your board's approval and providing them with the racial equity and health equity training they need to understand why we do this work. It requires investing in infrastructure, so you have the right data to be able to disaggregate data by race, ethnicity, language, gender, sexual orientation, to really identify where the disparities exist. It looks like investing in resources, so having dedicated teams who work to advance health equity and cross-functional collaboration to make health equity happen. Health equity is owned by really every area of the organization, which is the approach that DOHMH takes with their race to justice reform. Everyone has a contribution to advancing health equity. It requires convincing leaders to really change their approach to partnering with the community to advance health equity. How are they sharing power? Do they have patient and community advisory boards? Are they making investments in community partners? How are they partnering with reproductive justice organizations? Kind of all of these strategies both achieve are evidence-based ways to achieve and improve inequities in clinical outcomes, but also required necessary transformation at the organization level to really be able to achieve those clinical outcomes. So it's both health and patient-centered as well as organizational change. So a lot of my advocacy really focuses on supporting leaders and being able to make those changes.
Great, thank you. Tala, I really appreciate you bringing just not only like the different constituents that you kind of have to consider, because I think when we were putting on this event, we were very much community-based, but you're right, there is a lot of cross-partner organizations and leadership that needs to be considered too. So on servicing different populations, what is your approach to servicing the different communities or the different constituents in your work and making sure that their needs are met? So for Niteesa, Tala, and Sasha, a question that came through is, how does this apply to urban versus rural populations? And for Dr. McNatt, how do these approaches vary across the diversity of the neighborhoods in Brooklyn?
Yeah, I can quickly start. So 57% of Planned Parenthood health centers are located in rural or medically underserved areas. So much what we've learned from the work that we do with patients is that Planned Parenthood may be the only healthcare provider they see. So they see Planned Parenthood to get their sexual and reproductive health needs met. And that includes cervical cancer screening. It includes STI testing. It could include abortion, sexual education. Really, it's the gamut. But Planned Parenthood health centers are also providing COVID-19 vaccines. They're also providing linkages to behavioral health services and really other services that promote overall health and well-being. I think this is still emerging for Planned Parenthood. How do we build in the systems and the infrastructure to address all the social determinants of health and social needs that folks have? There are some affiliates across the country that are doing this really, really well. And affiliates are really centering their work and shaping their work to focus on the communities that they're actually serving. So to give you an example, PPLA recently launched a Black Health Initiative, which is an amazing initiative that focuses on improving sexual and reproductive health outcomes and building community for Black people within LA. And they specifically are focusing on Inglewood, which is an area that has a 40% Black population. Their work not only includes advances to clinical care, but they've created a community center that includes community engagement, partnerships with new community members, different educational courses, expansion of behavioral health. Soon they're going to include doula services. So they're really like tailoring and providing and expanding their care to their unique population needs. Because Planned Parenthood is such a large organization, those needs will look different from state to state, from city to city, from county to county, from zip code to zip code. And what we really hope is that the services that we provide are shaped and influenced not only by the core services, but the unique community needs and challenges. And for 57% of those health centers, they are in rural areas.
And I'll just say, to add to that, just to level set on what is happening on abortion access in this country right now. There are two things that are happening at the same time. Folks may remember in September of last year, of 2021, Texas passed a 6-week abortion ban, essentially making it impossible for anyone who is pregnant past 6 weeks. Most people do not know that they're pregnant at 6 weeks, but making it possible for people who are pregnant and after 6 weeks, who no longer wish to be pregnant, to seek the healthcare that they need, to seek an abortion, to get the access that they need. Following that, states across the country are replicating that ban. So currently, Oklahoma, Idaho, Georgia, Arizona, Tennessee, Arizona have all implemented abortion bans that sort of span between 6 weeks and 15 weeks. So all of those fights are happening in states where many of these states, there's very much more limited access. We also know that people oftentimes seek abortion services later in their pregnancy because they cannot afford it, because they cannot travel, or because healthcare is inaccessible in various ways, or because pregnancy then becomes a risk to their lives or to their life, which is why people seek out care within the legal limits of the law later than we might assume folks would. And so that's happening at the state level. And then nationally, the Supreme Court this June is set to hear a case called Dobbs versus Jackson Women's Health Organization. Jackson Women's Health Organization is the sole abortion provider in the state of Mississippi. Right now, there is a 15-week abortion ban on the books in the state of Mississippi, so that is already in play. And that's what's being litigated at the Supreme Court because it is in direct conflict with Roe v. Wade. We are expecting for the Supreme Court to uphold that law. And depending on what the Supreme Court says, there are basically 3 bad scenarios that will happen, significantly impacting access to abortion. And we could see access curtailed in up to 26 states. So it is dire, it is serious, it is national, it directly impacts states, the purple and red states all over this country. And then we'll see states like New York and California and Pennsylvania, et cetera, be what we're calling surge states, or places where people will travel. We're already understanding what will be true, or what folks are experiencing in places like Texas, where folks are getting in their cars, maybe with children, maybe with family members, and driving to access care, driving many hours. And so this is sort of the state of play when it comes to healthcare, and reflective of what we know when it comes to grave disparities in healthcare access. Period. We know it is Black folks, Latino folks, low-income folks, people living in rural communities. As Tala said, Planned Parenthoods are already in servicing rural communities all over this country, but it is people who already have disproportionately less access to healthcare. Again, that is a set of choices by design that will be disproportionately impacted by these bans. And so the stress that we are going to be under is enormous. We don't think people believe that this is going to quite happen because many things are happening in the world. Gas prices are going up. The cost of things are going up. There is war in Ukraine, like many things are happening. And this hasn't quite sort of hit our consciousness, but there will be a moment in June when we expect this decision to come down, where folks will sort of have this reckoning with what is true around reproductive health access. Last thing I'll say, and then I'll shut up. We were talking, for example, to folks who are Planned Parenthood providers in the state of Arizona. And so they have already said, like, the entire half of the state, sort of if you cut the state in half and look south, they're already recommending that rather than folks traveling in California, it is actually easier, more accessible, and more affordable for them to send patients to Mexico. So that's what we're experiencing in terms of the scope of access and care. when it comes to basic reproductive health care in the United States of America. So this is a national issue, and then its legs show up, of course, in all of our communities all over the country.
I'm happy to jump in and give a response as well. When we think about digital research studies and virtual research studies as well, like I mentioned before, a lot of the studies that we're doing and the diseases that we're looking at, they predominantly affect women, African-American women, Black communities. And so when we're asking people to participate in a research study and we need to collect your data using like an iPhone or an Android or Apple Watch or Fitbit, part of the conversation, similar to what Tala had mentioned, is like advocating to the stakeholders, to the people that are stakeholders and that are sponsoring these studies, letting them know, hey, like, these people that live in like this specific community, if we want to look at New York City, or if you want to look at Los Angeles, they're not able to afford Fitbits and Apple Watches, particularly depending on the income that they make a year. So a lot of times what we do at Evidation is we'll send devices out to people that are involved in the research study so that they're able to actually participate in the research study, and so that we're able to collect the data as well. And so that it's not skewed. It's not skewed to people that are in a higher socioeconomic status because they can afford to purchase these different devices, but making sure that we're leveling that playing field and providing the devices and even the resources that people need in order to participate in that research. At a grander level, if you take a look at it, the research studies that are even going on right now with COVID, all those things trickle down to the vaccinations that are administered. And so the data that we're collecting now, that will really affect the way that people are responsive to it, especially the people that are involved in those different types of research studies that had access to the resources that they need to be involved in it and also just participating in it. So that's my little piece there.
Excellent. Thank you all so much for sharing. I think what I would highlight in the question around sort of how do you address the differing needs across a variety of communities, a few things come to mind, right? So I think Tala has really centered a conversation a little bit on data. And data is often kind of the beginning for many of us of how we know an inequity exists and where it's taking place and who is impacted and perhaps even how it came to be. And that level of investigation, I think, has sometimes occurred in public health, but other times really hasn't, right? We've often just said, there seems to be a difference, and that difference must just be a result of your identity, which is absolutely incorrect. And yet that's where we've often landed historically. And so, the first piece for us in a lot of our work is, what does the data say is different or similar about the communities that we're serving in order to figure out how to be most supportive and what kind of service delivery or policy work or advocacy work is necessary. And so as you're thinking about kind of where you are in your own career progressions and what skill sets have become really important, I think that tends to be a really important one as we come to the table in these domains. I think the second is that for us within the Department of Health and Mental Hygiene, it's also really thinking deeply about who is supporting the communities that we've chosen to be engaged with, and how do we build teams that are community led. So are we hiring from the neighborhoods that we say that we want to serve, or are we hiring from other neighborhoods and making, doing job creation for folks that are not from disinvested communities? And so I think the second piece I would highlight is, how do we build teams that are reflective, and not just sort of physically reflective, but are reflective of the experiences and the perspectives and the journeys that are happening in a neighborhood. And then the third, I would say, are really active community partnerships. So specifically for a government body, right? Like, government bodies are not well trusted. We may sometimes even not come across as trustworthy, right? And so here are neighborhoods and communities trying to understand, how do I engage with the government body? And that's not just New York City or the United States, but all across the globe, there is a level of distrust. And so who are the community partners within a specific neighborhood who have a deeper understanding, a deeper historical connection, and who can even push on government bodies to be more accurate about their work and more fair and more just. And so I often think when we're trying to understand how to serve a community, we're looking at data, we are hiring and recruiting from within that community, and we are partnering with community-based organizations that frankly are often better at all of this work than we are, and trying to help really large structures like a government agency to become humble and to follow community-based leadership, I think is the important work of folks like ourselves. When I think more specifically, I just wanted to give an example of in Brooklyn and in Harlem within the Department of Health and Mental Hygiene. So we have these buildings called action centers. So Brownsville Action Center in Brooklyn, and an action center in East Harlem, and also one in the South Bronx. And I flagged them for a moment just to say that as the DOHMH and other sort of organizations think about how do you respond to a community, these very specific approaches that allow for that kind of data, partnership building, and hiring from within communities are really important. And so in the Brownsville example, maternal health is one of the areas that we're championing, and folks really understand that data. And within the Harlem context, we're thinking deeply about asthma and chronic disease, and all of that being based upon what the data says, what community members have shared as being concerns that are of great importance. And our goal really is to partner well, to hire well, to give back to communities in a variety of different ways, and to utilize data for the decision-making and the actions. And then quite frankly, ultimately, you have to be holding yourself accountable. Are the indicators moving? Are we decreasing health inequities? If it's exactly the same as it was 10 years ago, then what are we doing incorrectly? And how do we hold each other within our institutions and outside of our institutions accountable? And all of those things are harder than they sound, and require a great deal of collaborative spirit, and also, quite frankly, the stamina to keep pushing in a variety of different directions. And so that's what I would share in relationship to how do we decide how best to serve communities that may be different and similar in a variety of different ways. Thanks so much.
Thank you. Thank you. So for our final question on this panel, before we go into breakout sessions, and we'll make it quick so we have enough time, what is one thing that folks can do today to start exploring their passion for health equity work? What practices are needed to be innovative in this field?
I can start by giving a response. I would say, understand what are the things that you enjoy doing. What are the things that, you might not enjoy doing, so that you're aware for yourself, and what are the things that you want to be challenged on. Additionally, I would say network with people. That's the best way to understand different people's roles and their responsibilities within a company, so that you can get a better perspective of their day-to-day jobs, versus, possibly applying to a job very blindly and not understanding, what the day-to-day looks like as well. I would say look into, what are some of the upcoming innovative things that people are doing. I know that Evidation is very different in what typical research looks like, because we're running all of our studies virtually, and we're using wearable devices to understand people's disease management. So look into things that are up and coming, look into non-traditional routes, look into things that, might not be necessarily what people would say is the typical or traditional route as a social worker as well. And make sure that you have a narrative for yourself. Be ready to, like we talked about, be ready to advocate for yourself and tell a story, paint a story for yourself. Everyone talks about the elevator pitch. So, put that together and make sure that, you're able to convey what you're passionate about, and how you also intend to, make a change, within health equity and social justice. All the panelists today, when we gave our introductions, we talked about, what rooted us and why, what drives us. And that is what's going to be part of the determinant of after you graduate and you take on your job, a determinant of that is like what you're really passionate about.
I can go. I would say build your skill set in being able to analyze, interpret, and communicate data. It's just essential to doing health equity work, is being able to really dive deep and understand the disparities, and being able to communicate those in a way that influences change and takes action. So that doesn't necessarily mean you need to be like a hardcore data analyst, but like some level of data literacy and communication. And then like think critically about whether you want to have the experience of being in a clinical setting, or whether you're or providing direct service within a community organization, or more, whether you want to work in an institution that is really supporting clinics and direct service providers. So, DOHMH, Planned Parenthood, we're really providing support to those institutions at a much more macro level to influence policy and systems change. But I do think that there's, both of those experiences are really beneficial. I've never worked in direct service or clinical care. And I think the folks that do see firsthand the inequities more than anyone. So I think that could provide like really nuanced perspective about a specific community that you're interested in, or neighborhood you're interested in, or population or subpopulation you're interested in. So think about kind of both arenas, and what stage depending on what stage you are in your career, what would be most helpful for your learning and your goals.
I'll say you can do equity work no matter what your role is in this work. If you are a clinician, you can do equity work by centering and serving and providing services from an explicit anti-racist frame. If you're a program manager, you can do health equity work by making sure that directly impacted folks are in leadership roles to be able to design the change that they need. If you are an administrator at an organization, you could make policy changes at your organization by making sure the lowest paying staff are not making poverty wages, and we're elevating everyone and lifting all tides. If you're an executive director at your organization, you literally hold the keys, and you can move your board and your funders to invest deeply. If you're a medical provider, if you're like a doctor, a nurse, or a tangential to folks in those roles, as a social worker, we can sort of move our systems. Like there's no one way to do this work. It is a lens through which we do the work, rather than a practice, rather than like, I'm the health equity person and I can only do it if I'm the organizer. Like we all have a role. And so I think just finding yours is really key.
Thank you all so much. That is in total agreement, Sasha. The things that come to mind as we transition into the breakout sessions, I think part of asking the question, what can you do, is determining where you are in your journey. I think that sometimes the answer is you just need to read, right? Like sometimes you're starting in a place where you need to consume the information that helps understand context and understand sort of historical context, and then what's possible in the future. And some of the texts that come to mind in this particular topic include one that's really popular on medical apartheid, the text around an American health dilemma. There are really great histories of how we got to the place where we are in New York and in the United States in relationship to health equity and justice. And so I think the answer is often sort of, where are you in your journey? And so one aspect is reading. I think the second is taking some sort of action. And if you don't know how to do that yet, that's okay, and like attaching yourself to some movement work. And a lot of times within our professional spaces, that may not be what we do, right? But I think in your social spaces, even being able to attach yourself to movement work, the Campaign Against Racism, which is a very focused sort of health and justice group, whether it's Black Lives Matter, is a lot of different ways to be connected to movement work at the most grassroots level. And even if you're going to end up being executive director and senior vice president and all of these other titles, I think that that kind of work is the most beneficial to understanding what's really happening, so that when it's your time to be able to influence, and hopefully that's all the time, but when you feel like you have great resources to do so, that you're well informed as to what's happening on the ground. I would say, for those who are maybe spending, I don't know what your career journeys have been like. I often speaking to folks who are getting a bachelor's and then a master's and then a doctorate, and packing that all in because they feel like that's the academic journey. And I think that's beautiful. I also encourage just jumping into the work, right? And getting your feet wet and getting a sense and being able to offer up, I think as Tala said, great analysis of what's happening in that space. And then lastly, I would just say, find a way as often as you can to be listening at the most grassroots level, no matter where you end up in your profession. The answers are there. They're very rarely in the boardrooms that we're sitting. They're very rarely in these really high, powerful spaces. The data might be there, the academic sort of, growth might be there, but the answers are very often not there, which is why we are so far behind in public health or global health or a variety of other domains, because we've decided that some voices and some perspectives don't get to sit in the halls of power. And so listen at the most grassroots level and to your best ability. I think Sasha said it, like create a space for folks to be in the halls of power and then step back and let the beauty of advocacy happen. And so it's a pleasure to have met you all and to have been in conversation with this panel, and just a delight, and hand back over to Samantha.
Yes, thank you all. If everyone could please join me in thanking our panelists today, whether you're on camera, use the emojis and whatnot. Before we actually go into breakout rooms, I'd also like to introduce Yul Napier, the Executive Director of the Bureau of Brooklyn Neighborhood Health, who will be joining Dr. McNatt in the Department of Health and Mental Hygiene breakout room. And Yul, just one thing that folks can do, what's one thing folks can do today to start exploring their passion for health equity, in your opinion?
I think all of the panelists touched on it, but I think it's really leading from a place of understanding. I know my journey, I didn't have a public health background, but what connected to me about public health once I started working for the Center for Health Equity is the fact that data made the racism that I experienced as an African-American male growing up in New York City real. Because it's something that we always felt, the police brutality, the things that we experienced. But when I started working in public health, to connect data with that, and to really see the connection of poor health, poor nutrition, lack of opportunity, and how it intersected with health, that made it real to me. And that kind of sparked my interest in public health, although I didn't come with a background in public health. So really lead from a place where you feel comfortable, and hopefully it sparks something in you, and just be open to taking new opportunities and new experiences. And for me, again, that was me even delving in to the field of public health, being that I have my background as a master's in public administration. So that's just one thing, just remain open to the possibilities as you go through your journey, whether it's your master's, whether it's your BA, and then once you get into your careers.
Thank you so much. So thank you all for joining us for this first part of the panel. At this time, I will stop the recording.